May I invite Dr. Ravikumar, Senior Intensivist at Child's Trust Hospital. In Dr. Thiru's words, he's a most sincere, humble and responsible intensivist that is very reliable. And Dr. Ramesh, a pillar of Child's Trust Hospital, senior most anesthetist, and above all, a humble human and exemplary pediatric anesthetist for the past 35 years. He was the first person to start the pediatric ICU in India, and he's played a key role in formulating difficult airway guidelines in India. He's a much sought after teacher in India and abroad, and we all got to know his kindness earlier this morning. He treats everybody really kindly. And then we have Dr. Rahul Yadav, is he here? Dr. Rahul Yadav, sir, is a senior neonatologist at Rainbow Children's Hospital, and sir is a man of multiple interests. He's written many books to his name, and the latest being on the Ukraine war. And he's a person who proves that it is possible to live without WhatsApp.
Hello, Dr. Sandhu.
Yeah, hi.
Hello, Dr. Sandhu. Dr. Ramesh here. Yeah.
Ramesh, sorry, I didn't see you.
That's all right. You can't see. I just
so
want
nice.
Nice
Pleasure to see you. Thank you so much.
Many times I've listened, and every time I listen the same topic, we learn a lot of things. Yeah.
Not at all. You know everything about this. Thank you.
First, I need to thank the RA team for giving me this opportunity. So, as like other speakers, I am not a relevant person here. I am an intensivist. So, I am a disclaimer here. So, I am not a surgeon or anesthetist. So, with this, I will start on the intubation-related laryngotracheal injuries. This part has been taken care by Dr. Sandhu. So, the injury percentage is more common in children, as the presentation is much earlier compared to adults, and it is very much variable because the presentation of symptoms and referral is very less in an Indian setup. So the mechanism of injury has already been discussed by Dr. Sandhu. It is direct injury causing ulceration, granulation, as well as leverage on the posterior, which is a more severe injury. Presentations are very wide, and comorbidities are an important factors for predisposition. Okay. With this, I'll go to the scenario for the panelists. Then I will a short presentation of KKC data. Then again, final questions to the panelists. So here we have a 4-year-old child with global development delay seizure disorder brought to the ER with active seizures. This child gets AED, seizures persist, and child was intubated for poor sensorium. A routine scenario which happens in our ER. And this child got intubated by the PG in the second attempt. This happens here in our ER also. Seizures were controlled, child comes into the ICU. Child got ventilated for a period of 16 hours, not 16, around like 1 day. Midazolam infusion was on, it was stopped, seizure free. Then child does not wake up. Child was put on support mode and child is moving on the ventilator. Child is extubated. Post extubation, this child remains sleepy and develops noisy breathing. Child will wake up on stimulation but again becomes drowsy. With the concept of a child being global development delay with a neurological patient, it is always difficult at the bedside to determine whether it is a neurological component of stridor or there is a component of upper airway obstruction. Okay. So this child was started on adrenaline embolism and dexamethasone in view of stridor. Question to the panelist here. The first question is, in this type of patient where there is a component of a neurological stridor which could not be eliminated clinically, when should you go for a airway evaluation? Dr. Thiru and Dr. Sandhu can answer.
Dr. Sandhu?
Yeah. You want me to answer that?
Yeah.
Yeah. So I think the answer to the question is whenever you want us to go in and have a look. I mean, if you think that there is a cause which can or I mean we are not losing out anything. We have the endoscope, we have everything, and if we are able to rule out a local cause, then that actually makes it easier for you. But what is more important is that you want to know also the dynamics, in the sense that are we looking at, you said that he was intubated by someone who probably did not have too much of experience. So are you looking at a subluxated larynx? If that is the case, then dynamic examination also is important. So I think apart from the timing, so the timing is really there's nothing like timing. If you are suspecting that there's something going wrong somewhere, just put in an endoscope and have a look. And second part is that, what is more important is that what are you wanting to look at? So you want to look at the dynamics, and at the same time, you want to look at the airway. So you need to sort of, have the conditions of the child to do these kind of investigations as well.
Yeah, absolutely. Because most of the time there will be surprises. We will think that it is only neurological component. We'll go in and see there will be some lesion, and when we are very sure that there is something causing airway obstruction because of some injury, then there will be absolutely fine, neat airway. So it will not be predictable. So it's better to go and do a scopy whenever you feel like, and that's what we have been doing. And also, Dr. Sandhu, Dr. Kalan is online, so we can also get his opinion now and then.
Yeah, Dr. Kalan can also give his opinion regarding this.
No, I fully agree. I think the moment that you wonder if there's something wrong structurally causing the stridor is the moment to go and do the endoscopy and look, as Dr. Sandhu said.
Okay. The second question is, Dr. Sandhu has already pointed out during his talk. Dr. Ramesh, can you point out what would be the risk factors in this child for a airway injury with this whatever information given above? So could you focus on like the technique of intubation?
I'm very sure, but I think it has been very clearly told. I think if you see the history, I think the second year postgraduate and that to pediatrician. I hope no pediatrician. Any pediatric? Not about intensivist, I'm talking about pediatrician.
So sometimes you could ask for more.
So I don't think you can ask for more. The reason for this, because very clearly it has been told the experience makes all the difference. Number one. Number two, my thinking is that if you go to PICU, the child will be moving, fitting, and they will give a midazolam and try to intubate. I think that is the cause for this particular case. Okay, I think that's a very important. I'm not blaming the postgraduate. I think it should be a supervised intubation. I think that's a very, very, very important in this, because it should be a senior person. Because junior person is very hesitant to give a more relaxant or giving a propofol. So they'll give which is safer. They think midazolam is safe, so they give little midazolam, and that will be the injury. Because acute injury like this, more likely I'll blame the technique and the experience, and what they will show, they do according to theory. This size, this child will have 5 size tube. They will try to push 5. If not going, they'll put 5. So I think that is not right. You see, put 4.5. As you see that smaller tube airway is good enough. You don't give like. Initially, you just want an airway, so size doesn't matter. Put a small tube, just do that and fix it up. Let the senior person come and change it, or next day they can come and do it. I think that is the main. Whatever I see, the experience, it should be a supervised intubation. Third, it will be a good sedation if possible. If you are very good, you can paralyze as well. Then your injury will be much less. I think what is the present usually say that if you are in doubt, please do a scopy. This is what it is. Because scopy, you have no airway problem, then put the blame on the central stridor. Then thinking it could be a central or it could be a periphery. What is your problem? It is stridor. So I think we should have put the tube. So you just have to see. Just now these days the endoscopy is much simpler. We have got a better things are available. We have video things. You just put it and see there is no problem. Then I think you can put the blame on the.
So regarding PICU discussion, we can discuss over coffee later also.
I know Bola is there, but doesn't matter. That's okay.
Okay. Dr. Sandhu, like what is your opinion about using cuff tubes? Because now for pediatric intubations, cuff tubes are more recommended. Any opinions about it? Using an uncuffed tube will be favorable for preventing injuries?
So I think as you must be knowing already, of course. I think the type of the tube really depends upon what is the intention of intubating and where eventually the patient is going to be, lying, or what kind of pathology he has. Is he going to require ventilation for a long time? What kind of ventilation he is going to require? So I think, I think you guys know it even more than what we do, the cuff tubes and the non-cuff tubes. Of course, we do know that there are problems with the non-cuff tubes, there are problems with the cuff tubes. So I think the indications really come from from all of us together, and it needs to be personalized for each patient. Just to give you an example, the case that was referred to us from Greece is a 12-year-old who had COVID-related ARDS. Now, come on, we can't have a non-cuff tube to be inserted in him when he comes into the hospital. I mean, I'm talking in Greece. So in Athens, what the intensivist did was absolutely right, because he was confronted with that problem. So we shouldn't be sort of throwing or accusing someone. It's just that he or she who's actually the first doctor who is in front of the patient. I'm sure they are doing their best. But of course, there should be certain guidelines, as Ramesh very clearly pointed out, that we need to have certain guidelines. Our juniors need to know what are the limitations of all these devices. And I think regular training of these colleagues of ours is very, very critical. I include the nurses in that as well, because they play an important role in all the nursing issues in the intensive care.
Yeah. Thank you for the practical answer. The next question is, for want of time, I will not put a separate newborn scenario. Next question goes to Dr. RAHUL Yadav. In a similar setting where you have a newborn baby who gets intubated for a short illness, gets extubated as a strider, what is there a different way of wait and watch, or you will directly go on for airway evaluation, sir?
Yeah, so as far as this baby, it happens in newborn baby situation, we won't be worried about actually whether to evaluate or not. Because since our margin of safety is very small, we'll be worried whether he will be going to require re-intubation or not. So in that case, we usually follow the rule of CC. One is cry and second is CO2. In cry, we see duration of cry, pitch of cry and volume of cry. Duration of cry depends on CNS. Here this baby is also having CNS problems. Our preterm babies they cry very briefly. The cry is getting shorter and shorter. Second is pitch of the cry. The pitch is getting actually changed. Second is the volume of cry, intensity of cry. Intensity of cry will tell about FRC. So FRC, local lesions and duration, everything. And second is CO2 buildup. Based on the CC formula, cry and CO2, we decide the urgency behind it. Because majority of these things are going to be self-limiting. If it's going to be edema or congestion. So unnecessary involving one more procedure can be actually harmful to the baby. And in general, our experience is once we decide to give ENT call, ENT surgeon comes next day. So automatically by the time ENT surgeon comes, the problem is solved, either this way or this way. Either the baby goes on intubation or the stridor starts reducing. The main problem comes up nowadays is since we are dealing with extreme preterm babies, 22-weeker, 23-weeker, they won't have stridor. We are getting these post-intubation problems without stridor. So when stridor is there in this baby, actually we are happy. These babies are not having stridor and having head bobbing and his oxygen requirement is rising, and then we are more worried. Because stridor requires certain flow. But these babies, extreme preterm babies, can't generate any flow. We are more worried. So absence of stridor is actually nowadays getting a risk factor for this urgent, more earlier evaluation, more chance of intubation.
Yeah, Dr. Thiru, would you want to add upon something for this?
Thank you.
Nothing more. Yeah, it's a.
I think I'm sitting in a wrong panel.
So it's a
go ahead.
It's a typical Dr. RAHUL Yadav answer. Okay.
And the training is also like that. When he gives a first call, so my fellow will come and tell me. So sir is calling. There is a call from NICU. I tell her. So don't worry. There will be another call. Maybe after six hours or so. Then we know. Okay. This is an emergency. We'll have to go. Otherwise, we'll go the next day. Then they'll say, "Oh, they called you for some case." Oh, that baby is all right. So that kind of thing also, like a good indication for us. Thank you.
Yeah. With this, I'll just go to the data from our child trust. So I have two sets of data. One is patients who have been admitted in our ICU, NICU, or from our ER. They have some laryngeal injuries, and the other is the patients who are referred specifically for airway evaluation, that is intubation-related injuries from outside. So the in-house data of 32 patients, where they are not referred for, they had some intubation in the hospital, and then they had some symptoms. So 12 patients, the first intubation was in PICU, NICU, or in OT. This means they have been intubated by reasonably good hands. So the risk of untrained personnel intubation is less in the 12 patients. Remaining 20 have been intubated by probably her ER doctor or a PG. Still the risk is there. And all patients were intubated twice or more, either because the first attempt was not there or the patient got extubated, re-intubated for a stridor. Majority of them were intubated for respirator. This means they have had either a semi-urgent or a semi-emergency or a emergent intubation. And 14 children were intubated cuff TT tube. The mean duration of ventilation was 10 days in this group and ranges 6 to 25 days. 13 children had shock, 2 had AK, 1 had MODS, and these factors have sometimes proven to be the increase the risk of airway edema. And the age-wise distribution you can see here, because our patients mostly are less than 5 years. So you can see 9 patients in the newborn group, 9 in the 1 month to 1 year, and 10 in the 1 to 5 years. More than 5 years is less. And coming on to the duration of invasive ventilation. So we can see here less than 1 week. That is not a prolonged ventilation still. 1 week ventilation is still less, but still they contribute to the major patients with airway injuries. 1 week to 1 month is 13 patients, and more than 1 month is 5 patients. Okay, and the different types of endoscopic findings what we had in our 32 patients is only 1 patient had subglottic stenosis who ended up going on for a LTR. The others had soft stenosis membrane 8, intubation granulomas found in 4, mucosal edema in 12, laceration in 10, and minimal mucosal injuries or erosions in 2. The site of injury predominantly subglottis, glottis 19, and 1 patient has supraglottic injuries. And that supraglottis has a tissue-like connection coming from the posterior pharynx into the arytenoids. And most of them improved with local stereo application. 5 required dilatation, 11 required excision membrane release, and 1 required LTR. And that is the first case Dr. Thiru did here. Out of this 28 children required re-intubation, further managed PACU after the endoscopy. 5 required tracheostomy, out of this 4 required trach for the primary disease. 2 of them were autoimmune encephalitis or a childhood spore sensorium. 2 had pneumonia where ventilation was difficult to get, and 1 was a child with Jab B encephalitis, went on for trach and then went on for LTR. That is the same child. All these 5 children trach were decannulated. These are like good prognosis for. We had 22 patients who were primarily referred for airway evaluation, Dr. Thiru, or to the hospital, where like 9 were male, 15 are female. 10 patients had subglottic type 3 or more, okay, severe varieties, and 2 had tracheal stenosis. 7 patients referred trach in situ, that is, they came with a tracheostomy from other hospital. 5 out of 7 had SG, that is subglottis grade 2 or more, or tracheal stenosis. Just like a comparison, you can see patients who are referred or more, like newborn referrals are very less. Probably doctors.
Rainbow, sir. It goes to rainbow.
So probably newborns, NIC people have to be given more information about when to pick up all. We can get the clues from Dr. Rahul Yadav and point it out. The age group of 1 month to 1 year, even you can see more than 5 years with stridor referred for aneurysm much more. And I just try to look at this variability, like patients who had upper airway obstruction symptoms less than 14 days, more than 14 days, and because they are patients referred from outside, we didn't have details for 6 patients. You can see here, many of them had symptoms more than, some had symptoms like around 1 month, 1.5 months, then they came to Dr. Thiru for evaluation. Okay. So endoscopy findings, you can clearly see there's a contrast of subglottis in 12 patients compared to only 1 in the patients who have been evaluated in our hospital. 2 patients tracheal stenosis. The amount of mucosal edema, soft stenosis are much more in our group compared to the outside patients group, or the intubation granulomas, lacerations. So when I looked at the patients who had more than grade 3 and tracheal stenosis, what happened to them with the symptoms? More than 6 patients had upper airway more than 2 weeks. Tracheostomy in situ are like 3 patients. 2 patients had less than 2 week symptoms. 1 we didn't have details. Why I'm looking at this? Like somebody who has prolonged symptoms before getting evaluated. Probably it is going to a mature form of airway obstruction or tracheostomy, as Dr. Sandhu was pointing out. Tracheostomy sometimes can decrease the flow, so it may sometimes increase the amount of obstruction. And endoscopic management as such, 4 patients, there is 3 patients required PCTR who were referred for airway problems. 1 required LTR, 11 required serial dilatations out of the 22, 4 required only local stereo application, and 2 required membrane release. Okay, 4 of them got tracheostomy, which came a decannulator. You can see the difference here, like dilatation, PCTR requirements, because they have been referred for airway evaluation. Probably they got referred little later. And those are these are patients who had grade 3 or more of subglottic stenosis or tracheal stenosis. 3 required PCTR, 1 required LTR, and 8 required serial dilatation. Some of them are not on follow-up, so we don't know exactly what has happened to them. Coming back to the same scenario, child improved with adrenaline ablation and dexavan 3 doses, improved in sensorium, minimal oversets of voice present at 40 hours. This child didn't go for an airway evaluation. Okay, so at this point, I just again open this question: should the child who is improving with minimal hoarseness go for an airway evaluation? If long, how long can we observe, and can airway injuries heal spontaneously? The question goes to Dr. Sandhu and Dr. Kalan. Dr. Sandhu available?
So, as I mentioned, in my first slide, that persistent dysphonia and persistent dyspnea, that includes stridor. Now that could be anywhere from 3 days to a week's time, 10 days time, is an indication for doing an endoscopy. We do know that there could be some amount of edema, there could be some granulation tissue. As long as it is not life-threatening, one can always observe. But if it is persistent, dyspnea, stridor, and dysphonia will require some kind of endoscopic evaluation.
Your comments, Dr. Kalan?
Not much to add. I think that's pretty common sense.
Okay. And the next question, like whether waiting for longer time or getting a tracheostomy without specific airway management at centers, whether this is going to increase the risk of severe airway obstruction problems. It's again, this question goes to Dr. Thiru, Dr. Sandhu, and Dr. Kalan.
Yeah, exactly. So of late, what we saw today in Dr. Sandhu's talk, how much of treatment is being done at acute level of injury and then intermediate period before it gets into a matured laryngotracheal stenosis. So in that way, sometimes it is a very simple removal of a granulation tissue, or just small dilatation, or just re-intubation with the one size smaller tube and and ointment application, neosporin H or deprogent ointment application around the tube. That will heal the mucosal laceration problems. So that's how we are able to prevent lot of severe stenosis. So that's what is happening. In case if there is some problem, we will be called. For example, there is a stridor, post intubation stridor. ENT surgeon will be called for tracheostomy. Some center, even now it is being practiced. You come and do tracheostomy. So ENT surgeon will go. He will do tracheostomy. That's it. He'll come back. Okay. Nobody would have seen what is happening inside. So what will happen in case if there is a treatable problem there above in the subglottis or glottis? If you do tracheostomy, then what will happen? The child won't breathe through this. Then there is not even a pneumatic stenting. So what will happen? There is going to be a severe stenosis later on. So whenever there is a problem, when you suspect, whenever there is a persistent problem, like Dr. Rahul Yadav said, cry is very, very, very important in a newborn. And older children, voice. What about the voice? Because we don't give importance to voice when we are talking about stridor. So even there is a problem in voice or breathing, it's better to have a look before doing anything else. Thank you.
Any other comments from Dr. Sandhu? And
So for me, I think one subset of patients one needs to really consider carefully are burns patients or caustic injury patients. Like for example, in burns patients, if let's say one decides to do a tracheostomy on, I don't know at what time, but for some reason the tracheostomy is going to be done earlier, one needs to be a little careful, because it's very easy to insert do a tracheostomy and to insert a stent, because you want the vocal cords to heal in a certain position, etc., etc. But I think burns and caustic injuries are a different subset of patients, where mucosa is extremely precious. And it may not be a bad idea to actually hold on for a couple of days so as to sort of, know the final truth about what exactly is happening at the mucosal lesion sort of situation in these patients before we decide that, all right, now is the time we want to protect the larynx and we want the larynx to heal in a certain sort of, way. So I think burns patients, caustic injury patients, these are a very special kind of subset of patients and they need to be handled slightly differently. Size of the endotracheal tube will be very different as well. Size of the tracheostomy cannula will be slightly different as well. So dry heat, I mean that is burns. Wet heat, that would mean that steam and these kind of burns, they are different subsets.
With this, I'll come to an end. Anyway, the practice at KKC is we involve the ENT team as soon as possible. Airway surgeon Dr. Thiru comes into the picture once there is a stridor when we manage. Patient seems improving and Dr. Thiru feels we can wait, then we wait, but still the patient will be followed up. Child improves, fine. Child does not improve, airway evaluation gets done. Or somebody who is worsening, definitely airway gets done. Thank you.
Thank you, Dr. Ravi. Thank you, Dr. Sandhu.